Now I'm requesting Dr. Nilufar Fatema for her presentation regarding echocardiographic assessment of storage disease of heart by 2D longitudinal strain imaging. Dr. Nilufar Fatema, please.
Assalamu alaikum. I am Dr. Nilufar Fatema, going to present a case. So my today's title is Thickened Myocardium, Thickening Well or Not. So Mr. X, 65 years, non-smoker, non-diabetic, hypertensive for last 1 year, short of breath, which is progressive in nature for last 3 years, started with NYHA class 1, now at NYHA class 4. Shortness of breath now at rest and lying position for last 2 months. Pulse is normal, blood pressure 150/85. Generalized edema, precordial examination, there is a pansystolic murmur in the left lower parasternal region, grading 2/6, and lung auscultation, bilateral basal crepitation. His ECG, there is LVH with strain pattern, and the limb leads are low voltage. And X-ray chest, mild cardiomegaly. Lab findings might slightly increase troponin I on presentation, 1.8, and proBNP is very high, it's more than 7,000. Creatinine is high, 3.2. Electrolyte is normal, but urinary shows protein 3+. So then we did 24 hours urine analysis, UTP shows 3.2, and volume is also decreased, less than 1 liter per day. This is the echocardiography, which shows the apical four-chamber view, which shows the LVH, and there is biatrial enlargement and mild pericardial effusion. And both the septal wall and posterior wall is 15 millimeter. And the short axis LV is very small. There is some brightening in between in myocardium, and also the visceral pericardium is thickened, and also there is echogenicity in visceral pericardium and mild pericardial effusion. And we did the volume assessment, LA volume assessment, which is upper limit 21.5 centimeter square. And ejection fraction 55 in Simpson's method. TAPC is reduced 11 millimeter. And color Doppler moderate tricuspid regurgitation, IVC less than 50% respiratory collapsibility. And aortic gradient is normal. Then mitral flow, EE is very large and A is small. So, and E by E prime is 2.79, and deceleration time is very short, 106. And the septal E prime is 5, lateral E prime 7, and E by E ratio is 13.03, which is suggestive of restrictive pattern. And TR velocity also 3.53, and calculated PSP is 57 millimeter of mercury. Hepatic venous pulse wave Doppler increase the inspiratory forward flow, and the inspiratory diastolic reversal is increased, and there is minimal expiratory diastolic flow reversal. When we see any LVH, then we have differentials in our mind. That is, we might deal with hypertensive heart failure or aortic stenosis or hypertrophic cardiomyopathy, or the cases may be chronic kidney disease. Then we focused in the interventricular septum, where we see the granular and speckles within the myocardium, and also interatrial septum is also thickened. Then we decide to do the global longitudinal strain, and these are the steps of strain. Then these strain give us the answer that we are dealing with a cardiac amyloidosis. There is a cherry on top appearance in the bullseye. And so the findings of the GLS is left ventricular GLS is reduced, reduction of the longitudinal strain and basal mid LV strain, and relative sparing of the apical segment, bullseye pattern. In bullseye plot, which is cherry on top, like this cake. So, the history of strain in diagnosis of amyloidosis, in 2010, Fogg groups described the reduced mean basal strain, and in 2012, Mark Wick's group coined the term apical sparing pattern. And Fallon et al. Showed they have taken 50 amyloid cases and compare with the septal hypertrophy case, 25 septal hypertrophy case, and 25 aortic stenosis case, and they have seen all the amyloid cases have the cherry on top appearance in strain imaging, and whereas the hypertrophic septal hypertrophy shows the focal reduction of the septum and also the aortic stenosis patchy reduction. And the third thing we should look for in global longitudinal strain, that is the relative regional strain ratio by average apical longitudinal strain divided by basal longitudinal strain plus mid longitudinal strain. If this ratio is more than 1, then it is highly specific and sensitive for the diagnosis of the cardiac amyloidosis. And high ratio also suggests that the adverse prognosis. And in our case, TAPSI was 11, and if the TAPSI is less than 14 millimeter, it predicts the higher event death rate. And longitudinal strain in RV can be done more than minus 17% also shows the predictor of mortality very high, and p-value is significant. We miss the early stage of this disease because of the asymptomatic vague complaint of the patient and non-specific echo finding. And we sometimes match with the hypertension, the case with the hypertension, CKD, AS or HOCM. But it is important to recognize the diagnosis of this disease so early that to improve the patient outcome. In disease progression, GLS also has some it is a useful marker. So other tests are cardiac CMR and radionucleotide imaging, endomyocardial biopsy, and biopsy from the other sites. And Mature et al. In 2017 in Circulation, they have shown that echo is the very useful recommendation for diagnosis. Very useful recommendation for the suspicion of cardiac amyloidosis, and also the functional evaluation of the LV, and prognosis, it has some role. So then we did the protein electrophoresis, which is normal, and free light chain assay, it gives us some clue that is increased kappa and lambda ratio, which indicates he might be a case of AL amyloidosis. And then we refer to the patient to nephrology department. They have done the renal biopsy, and it shows the Congo red stain positive. Congo red demonstrates the accumulation of the amyloid. It stained pink in color. These are the amyloids. These are the
Thank you, Dr. Nilufar Fatema, for your beautiful presentation. Actually, it's very encouraging that we are going to diagnose cardiac amyloidosis nowadays. Do you think this is a case of AL amyloidosis or something else?
I think it is AL amyloidosis because the free light chains, the kappa lambda ratio is increased. In many literature, they have shown.
For further confirmation, do you like to think any other investigation that may be important?
The gold standard in confirmation investigation is endomyocardial biopsy, but it is very difficult.
But that cannot differentiate between AL and ATTR.
ATTR.
In that case, you can think of performing bone marrow biopsy, and sometimes you can do bone scan. Thank you, sir. I'd like to hear some comments from Professor H.I. Lutfur, sir.
Thank you, Dr. Nilufar, for a nice presentation. I think it is not less common, but usually we miss the diagnosis. So we must be careful when we see that there is ventricular hypertrophy, granular echogenic myocardium, biatrial enlargement, biventricular failure, then we must keep attention to make the diagnosis and for further investigations. It can be diagnosed very easily if we are careful. Thank you so much.
Without failure?
Yes. In the early stages, there may be no failure at all. And that may be a subclinical case of cardiac amyloidosis.
Thank you, Dr. Nilufar Fatema.